We've talked about knees and hips, but shoulders carry a lot of our life. Shoulder problems, why and how and when surgery works. Tonight, On Call with the Prairie Doc. Good evening and welcome to On Call with the Prairie Doc. We have often expressed wonder at how intricate and functional our joints are. They usually work day after day, year after year without complaint. Sometimes, though, a problem occurs, and what we do then is our show tonight. First, let's take a look at this week's Prairie Doc quiz question. The shoulder is a complex joint of 3 bones. Can you name them? Viewers who call in the correct answer will be entered into a drawing to win a signed copy of our book, The Picture of Health. Each of my essays, originally written for this show way back there, comes with a wonderful accompanying photograph by Dr. Judith Peterson. We'll announce the answer and the winner at the end of the show. Remember, you only have 10 minutes to get your answer in. We answer your medical questions about shoulder health as they are called in or sent to us via Facebook or email. Call in your questions to 1-888-376-6225 or send us an email to the address on the screen. This is your show. Give us your calls. Opportunity to ask wonderful experts about orthopedic issues. Joining us tonight is Dr. Pete Looby and Dr. Keith Baumgartner, both of the Orthopedic Institute, Sioux Falls, South Dakota. Thank you guys for joining us.
Thanks, Rick. It's good to be here.
Definitely.
So we'll talk with you first, Keith. Where are you from originally?
Originally, I'm from New York City.
New York City?
Yeah.
And then you went to Hopkins undergrad?
So I went to Johns Hopkins undergrad and also medical school there in Baltimore, Maryland.
We're kind of a Eastern, hardly know that school, barely, known about. And then you went to where for your residency?
In St. Louis, Missouri, at Washington University, I did my orthopedic surgery residency.
Right, just kind of a slovenly school. I think top 3 med schools in the United States. You did your residency there in orthopedic, and then a fellowship?
Correct, in sports medicine, shoulder surgery in New York City at the Hospital for Special Surgery.
And so there you are, New York born, you kind of forayed your way out to Washington University in St. Louis, and you were looking to practice and you ended up in Sioux Falls. How did that happen?
Yeah, so it was an interesting story. I'm living in New York City and looking forward to starting my career and speaking with my wife, who was we're considering developing a family, and she tells me out of the blue that she doesn't want to live in New York City.
Now she's from L.A.
She's from Los Angeles.
Did she not want to live in L.A. or California?
Not either. She didn't want to live in a big city. She wanted more of a family environment. And so we looked across the country and had an opportunity to meet with the guys at Orthopedic Institute, Dr. Looby, and my initial impression was, who wants to live in South Dakota? And you know what? I took a trip out here and met the group at Orthopedic Institute and Dr. Looby and was really impressed by the practice. And then we looked around the community and talked to people and we said, you know what? This looks like a great opportunity. And we said, we'll give it a year. And this is our 13th year. Now have 4 kids here. I love it. I don't think you can get me or my wife out of here.
And your daughter said what yesterday or this morning?
Oh, my daughter said oofta. And
she is South Dakota.
South Dakota, correct. So didn't see that coming. Yeah. So
if you eat chislik and you say oofta, I mean this is South Dakota, isn't it?
So it's been great. We unless we get kicked out of the state, we're staying here forever.
Okay.
So, yeah.
That's a great story and a wonderful amount of training that you've had, Keith.
Oh, thank you.
Pete, so let's hear your story. You're kind of a South Dakota boy.
Yeah, I am. Keith's story is really compelling and fun to listen to, and mine is way more boring. I'm the son of an obstetrician gynecologist in Sioux Falls. My dad, Dr. Tom Looby, practiced there for 42 years.
Did he deliver you?
Don't think so.
Okay.
Yeah.
You don't take care of your own family.
Don't take care of your own family.
Yeah.
You know that.
Mm-hmm.
When I finished at Lincoln High School, I went off to Stanford University, and then I was in medical school down at Washington University in St. Louis, and did my residency at the University of New Mexico and my sports medicine fellowship at Harvard Mass General. And I married a Sioux Falls girl, my wife Catherine Sandberg. We were high school sweethearts, and when we got done with training, we just naturally moved home.
Came back?
Yeah, came back to South Dakota.
So Well, we're glad to have you both here in the state. And we're talking about shoulders. Now, I know you are just pure shoulder. That's shoulder, elbow, arm, right?
I'm definitely interested in the shoulder and elbow, but I do hips and knees as well.
Well, I mean, and you were on call. You fill in the responsibility as well. And you're kind of an all-around guy, or do more shoulders than, I mean, football. I'm seeing you as a football sports fixer-up.
You know, Rick, you're exactly right. And Keith and I have very similar trainings, orthopedic surgery and then sports medicine fellowship, which really concentrates on reconstruction of the knee and the shoulder. So he and I both have very busy knee and shoulder practices, do a lot of ACL reconstructions, meniscectomies, labral repairs, rotator cuff repairs, and then we both do joint replacement surgery as well.
Those meant meniscectomy, meaning that the meniscus of the shoulder, we're talking shoulder, right?
Knee.
Oh, of the knee.
Yep.
Okay. And then you said labrum?
Labrum, which is labrum is just Latin for lip. It's a lip of cartilage that goes around the socket in the shoulder. And unfortunately, individuals, especially young athletes, can tear that labrum and need to have it repaired.
Yeah.
Must have learned that in Harvard.
So I know that the shoulder is the joint that is the most able to do everything. I mean, if you think about it, your knees, your fingers, I mean, they're basically, they have one direction. They have very little side, but the shoulder does everything. So it has this wonderful freedom, but it loses its stability. Explain that to me.
Well, yeah, you're exactly right. The shoulder has the greatest degrees of motion of any joint in the body. A full 180 degrees. There's no other joint in the body that can do that. It's this amazing combination of flexibility and stability when it's working properly. But sometimes things go awry, and that's when we're lucky to have people like Dr. Baumgartner around to fix it when it goes bad.
Yeah. So the instability that people have, sometimes they have it because they were swimming and their shoulder popped out of joint, and then once you've done it, you've caused some problems. Is there anything that a person who is a high school kid can do so that his shoulder stays in good shape the rest of his life?
So before it pops out of joint, is that the question?
Right.
Well, typically having good strength of the rotator cuff is very important. And most people are born that way. Most people are asymptomatic and do real well. It's
Without symptoms.
Without symptoms, correct. It's the issue when you start developing symptoms. And if you're starting to notice that you're developing shoulder pain, instability, weakness, that's when you want to make certain that you try and catch up and make sure that the shoulder and the rotator cuff muscles are strong. That's the only quote-unquote preventative way of preventing injury.
So what exercises? I mean, it's this and this, this and this.
Correct.
And this?
So yes, so that's the scaption motion coming up through here, and that works the main rotator cuff muscle called the supraspinatus. This internal and external rotation are very important for what's called the infraspinatus and the subscapularis as well. Those are the three mainstays strengthening treatments there. There's some shoulder stretching exercises that can be done as well. But in a nutshell, you knew it right there, what we do on the rehab there.
Right. Yeah. So we're talking preventive exercises, and I have to say that I have a series of rotator cuff exercises I do on my little weight machine twice a week to try to strengthen my shoulder, because my dad had terrible shoulder problems. A lot of older people have shoulder trouble, and is it because of injury, or just because they're older, or because they have arthritis everywhere, or what, Pete?
Well, Rick, I think it's mainly your fault. The fantastic internal medicine doctors and the cardiologists in America have got us all outliving our joints. When the average life expectancy was 34 years in this country,
never had a problem.
We didn't have a problem, right? But now when people are living well into their 80s and 90s, we just kind of wear out. And some of that is from trauma, and some of it is just from heavy use.
Heavy use. So, see, there's that question. I remember I have an ears, nose, and throat friend, dear Dr. Robert Reeds, who says, I think you only have so many heartbeats, so many knee bends, so many shoulder moves, and then you wear out. And my point is, no, a regular exercise program keeps you stronger and keeps you alive a long, long time. Are you landing with Reitz or with Holm?
I'm always with Holm, especially when I'm on his TV program. I'm always with Holm. So in orthopedics, and Keith will know way more about this than I do, but there's a concept called Wolff's Law, which says basically that if you regularly stress a tissue, a tendon, a muscle, a joint, a bone, it will get stronger. Now, there are some limits to that, obviously, but people have been shown, for instance, to be able to increase their muscular strength until the day they die if you put them in a training program. So I'm a Holm fan on this one.
I'm there too. Now, what's your take on it, Keith?
I think it's a matter of both. I think that there's, over the time, our rotator cuffs typically degenerate regardless of what we do. If you look at the patient population 60 and older, there's some studies that suggest up to 10 to 25% of people have a full thickness tear of the rotator cuff. And interestingly enough, most people don't even know about it because they're not having pain, they're not having weakness.
And it happens sometime in their life.
Sometime in their life, probably just over the years that you get micro trauma and then it becomes bigger and bigger and then you get a tear there. And so that's where I think being strong and having that exercise program, if you're fit, you're probably less likely to have symptoms from that compared to someone who develops symptoms.
Okay, so it sounded more like you were on Holm's side than
You know I'm
Reed's
on your
side.
side.
So we have a Facebook question. Facebook works really well, guys. In fact, if you go to Arizona over this winter, you can watch our show on Facebook Live and call in questions from Arizona. Just to say, don't forget that. So the question is from a 69-year-old woman: how many cortisone injections can I have in my shoulder for tendonitis? I've had one injection a year ago and that helped, but the pain has returned. So how often? I know that there was a man who had terrible degenerative knees, had an injection a week from his physician, and he ended up presenting with Cushing's syndrome. Yeah. I mean, too much steroid on board, and all of his immune systems were down, and he got a severe infection and died from injections. Yeah. We can overdo them. So how often can you inject a shoulder or a knee or a hip or whatever?
Yeah, it's always a good question, a common question, and I think based on the orthopedic literature, a difficult question to answer definitively. What I tell my patients is, if you're needing an injection every 1 or 2 weeks, it's not doing what we need it to do, and we should look at some other treatment. If you need to have a shot every 3 or 4 months, and you're at a point in your life where surgery is not a good option for you, and the symptoms are severe, and the injections help, I think that's okay.
Yeah, and that's what I would say too as an internist. And of course, we always question everything orthopedic people think, you know, because we're the internists are the ones who really, we don't have any knives or any. All we have is naysaying, I guess, maybe. Yeah. So that, Keith, do you agree?
I agree 100%. It's interesting, if you take corticosteroid and numbing medicine that's often added to the shot, right. So cortisone and the numbing medicine, and if you put it on the cartilage cells or tendon cells in a petri dish, it can be chondrotoxic. But we haven't...
Chondrotoxic, yes. Meaning toxic to the chondra or the cartilage.
To the cartilage or to the cells there. So there's a whole question, well, does that actually do damage? Now, we've never seen that in the human body. And we actually did a study at the Orthopedic Institute and followed people for 5 years to see if...
You're doing scientific studies at your institute. How about that?
Yeah. And we didn't see any evidence of problems with the cartilage from doing injections of the shoulder even up to 5 years. Now, there's a difference between 5 years and 20 years, but clinically we haven't seen the problems there. But it's important to know that that's a potential concern, and you have to use the judgment to do what's best for the patient. And Dr. Looby's 100% right. If you're getting an injection every month or two, it's probably not working. It's probably not worth the risk of the injection. Now, if you have an injection every year and it's making your quality of life great, and it's not worth the risk of having surgery because you feel so great from the small risk of an injection, then the benefits of that may outweigh the risks.
Right, and I think 3 or 4 months, every 3 or 4 months is acceptable if it really works.
I agree.
So we need your questions. The number, if I had it on the top of my head, was 888. Oh, I don't have it here.
It's on the screen, though.
376-6225. So, I mean, please give us your call, ask your orthopedic questions. So, orthopedic problems in the shoulder occur mostly, oftentimes in non-athletes, though. I mean, these farmers who've been working too hard with that shoulder. I think the boomers are going to be rolling in on their shoulders. They want to be able to do everything they want to do. And that's kind of the way we are. I'm a boomer and kind of spoiled, always had everything I wanted. And do you think that we're going to overdo the shoulder surgeries and the knee surgeries and the hip surgeries in the time coming as boomers get into their 70s and 80s?
Well, I hope we don't overdo them. I hope we use them wisely to help people to continue to be active and healthy and able to get out and have that active lifestyle that they're used to and want to continue to do. Keith earlier in the radio spot made the point that a lot of these things can be treated non-surgically, and that's almost always our initial approach, Rick. And then use surgery as in most cases, a last resort because the non-surgical care is not working well. Now there are times when the patient comes in and I just have to sit them down and say, you know what, we got to fix this, because if we don't fix it, we know what the natural history of this problem is, and it's not good for you.
Right.
Let's get this taken care of, and we'll go forward from there. But most of the time, we use the surgery as a backup plan.
I think of it as people who stop moving. Their muscles atrophy, and their chances with atrophic muscles, weakened muscles, thin muscles, non-functional muscles, to recover from surgery gets poorer and poorer. So that you want to have functioning, you've got to be moving, but if it's hurting you so bad that you're not moving and you're getting into a point where your muscles are going to start atrophying, then you need to get it done. Would you agree with that?
I agree 100%. So, if you're heading in the wrong direction, if non-operative treatment's not working, at some point you gotta consider doing the surgical intervention. And we do know that if the rotator cuff muscle belly atrophies, the chance of successful repair is a lot less successful than with someone who's got full muscle and no atrophy whatsoever.
So, and so we're going to talk about rehab, but I have a question from Roscoe, South Dakota. And she would like to know what is a frozen shoulder and what's the treatment of that?
Sure. Frozen shoulder is also called adhesive capsulitis. Typically affects more women than men, normally in the age groups of 40 to 50. Most of the time, it's what we call idiopathic. Sometimes I say that doctors aren't smart enough to know why it happens.
That's what idiopathic is.
Right?
The idiot just can't figure it out.
Sure.
That's right.
So, but it's also associated with diabetes, cardiac disease, and thyroid disease.
So that again? Thyroid disease, cardiac disease, and
diabetes.
Really?
Yeah.
Didn't realize. More adhesive capsulitis.
Correct.
In that group.
And so what happens is the capsule of the ligaments of the shoulder get inflamed. And so the first stage of it is severe pain. And the second stage of it is severe pain plus stiffness. And the last phase, which is called the thawing phase, is that the pain goes away and you start getting some of your range of motion back, but you typically don't get all of it back unless you get treatment. There are some studies that suggest if you leave it alone for 1 to 3 years, it resolves. But what typically happens is you end up with having a stiff shoulder. And I know very few people who want to wait 1 to 3 years for their shoulder pain to go away.
Right. So it used to be you just take them to surgery, anesthetize them, and then break through the frozen shoulder, make it go in all the directions, and break whatever was scar tissue. Now that's the old way, but we do that different now, don't we?
Yeah. So first of all, I normally try non-operative treatment. I normally do a corticosteroid injection, what we talked about earlier. Yeah. 1 or 2 of those. Physical therapy.
With physical therapy.
Correct. Combination 2. I think it works synergistically. In other words, it works better if you do both at the same time. And at Orthopedic Institute, we did a study and found out that we had about 80% success rate with non-operative treatments for this problem. Now, if it doesn't work and you go on to do surgery, what you mentioned was called a manipulation under anesthesia. And what you do essentially is tear the ligament that's tight. And nowadays, we do it arthroscopically, where we surgically incise the ligament right where the surgeon wants to incise it. And I feel like it's a lot safer and more effective surgery because there have been some people that have fractured the shoulder doing a manipulation. The chances of fracturing your shoulder after a capsular release is a lot less.
Okay.
Pete, is that how you do it?
You know, Keith, I'm a little older than you, so my approach is a little different. I can't remember the last time I took a patient with frozen shoulder to the OR. I sit them down, I have a nice conversation with them about what this thing is and what the natural history of it is, and I basically treat them all non-surgically. I reserve manipulation under anesthesia or lysis of adhesions through the arthroscope for my very difficult patients, but it's been years since I couldn't get someone through this non-surgically.
And it's the steroids and the physical therapy.
It's the therapy, it's the talk therapy, it's the medications, and it's the physical therapy.
But isn't it the lesson to us all that you got to move a joint or it's going to freeze? I mean, it's going to stop working, it's going to get stiffer, it can go and develop pain. You got to keep moving.
Yeah, I think that's true, but this condition that Keith and I are talking about is different than that. We don't, as Keith said, we don't know what triggers this, what causes it, but it's a real pathologic condition. If you take a piece of that capsule around that shoulder joint and look at it under the microscope, it is in disarray. And when you and I were kids, they used to have that shrink art stuff. You'd cut that piece of plastic and your mom would put it in the oven and it'd shrink up to 1/10 of its size and make this beautiful little bauble that your dad couldn't care less about and threw out after you gave it to him. Well, that's basically what happens to the capsule of the shoulder. This thing normally is billowy, gorgeous, and in adhesive capsulitis, it just shrinks right down and captures the ball onto the socket so it could barely move in severe cases.
So we'll talk more, but we've got more questions. Very good. A man from Brandon had knee surgery about 40 years ago, and they took out his ACL, anterior cruciate ligament, part of the knee. His knee had been bone on bone since 2006. Is there more risk if he waits instead of seeking care? He doesn't experience pain but does have stiffness. Pete?
Well, if he's not having pain, I would say it's reasonable for him to do a home exercise program to maintain fitness, range of motion, and strength. I don't see any value to rushing to invasive treatment for an individual who's not experiencing pain.
Okay. I've got a 14-year-old nephew, broke 4 metacarpals on one hand, metacarpal meaning this bone, these bones in the hand, 4 metacarpals in one hand while playing football. He's getting a cast that will allow him to continue playing football. Is this wise, Keith?
Well, first of all, I don't want to make any judgment without seeing the x-ray or not being the treating physician. So I think that I want to give some discretion to the treating physician because they actually know the case. It all comes down to these metacarpal fractures if there's any rotational deformity. So if the fingers rotate and you can't make a closed fist, then those need surgery. But if you can make a closed fix without any rotational deformity of the hand, the non-operative treatment such as casting is appropriate. There are times that I do let my patients who are football players with metacarpal fractures play in a cast. It's difficult to say in this circumstance, but I have done it before.
So, I mean, the time that I've seen metacarpal fractures are drunk college people hitting walls. Yeah. I mean, that's what it may not be college kids, but it's young people who are often alcoholically overdone, and they're in a anger thing, and the girlfriend just dumped them, or they're a threat to somebody. It worries me. And then they hit a brick wall, or they hit they put a hole in a plasterboard or something, and they break their metacarpals. Yeah. Is that the common?
Yeah, that's the most common metacarpal fracture, what we call a boxer's fracture. It usually occurs in the 5th metacarpal, the one that goes to the small finger, just at the neck of the fracture. Those are usually treated non-surgically. If there's significant deformity to them, they may need to be reduced and pinned.
Yeah, the 4 metacarpals makes me think that would be a surgical repair, but you're right. Let's give it to the...
So there's a good chance in that circumstance that they were stepped on or it was a direct blow. And in those circumstances, there's very little displacement in that scenario. But again, I would have to see the x-rays to give a thorough recommendation.
Okay. So after you have your shoulder repaired, what do you need to do to keep it healthy and fully restored and to fully restore movement?
People come to physical therapy for shoulder problems for 2 primary reasons. Number 1, pain, and number 2, which is probably more importantly, is the loss of function. At least 25% of my day is spent specifically on shoulder issues. whether it's post-surgery rehabilitation, if it's pre-surgery rehabilitation, or maybe after an injury and accident. Often we work in conjunction with the orthopedic surgeons. The patient might go to see the doctor, and the surgeon will perform a thorough assessment, and often they'll make a decision, hey, let's try some physical therapy to see if we can avoid surgery. We call rehabilitation prior to surgery, we call it prehab. And that is sometimes what we'll do with a patient to try to strengthen other surrounding muscles, try to get back range of motion prior to the surgery to help the outcome after surgery. Trying to get the arm moving through the full movement to reach up, reach down, out to the side. One of the big functional movements we work on quite a bit is reaching behind the back. Think about how many times you want to tuck a shirt in, or maybe someone needs to hook a bra. We need to have that ability to reach behind our back. It's very, very important. Post-operative rehabilitation is something that we work in concert closely with the orthopedic surgeon. We will follow a protocol, and within that protocol, often we start with range of motion exercises. This is a very common maneuver post-surgery. We might be working with a person, we might short range. Okay. When we have patients with shoulder impingement or a pinched tendon, we'll work on this direction of movement. To start with our rehabilitation, as I had mentioned before, we use range of motion. So we might use an exercise ball to work on full range before we actually even throw the ball. So once we get to the point where they have the range of motion, they can throw the ball. Our next steps in that process would be, for example, using a pulley or a stick to assist with that range of motion. We then progress to isometric strengthening and isotonic strengthening, like with rubber bands, like a TheraBand, things like that to help build strength. Then we work towards functional things, like reaching into a cupboard. A common piece of equipment that we use in physical therapy is elastic tubing. This is a tubing or band, usually non-latex. It's something we can integrate into strengthening exercises with a patient. We work on rotator cuff strengthening very often with this type of exercise. Maybe we do a single arm, we can do a double arm. Shoulder problems take time to work on. It's not something that's going to get better overnight. When we work with a person, we want to teach them and educate them on their problem. And part of that education is giving them a little bit of a patience and showing them it'll get better. The key is to continually work on it and not give up.
Thank you, Chuck, for that. One of the very important persons in Brookings, South Dakota, Chuck, and he mentioned prehab in the video. So prehab is before surgery, right? Rehab, only prehab. Explain the value of prehab and what it's all about.
You know, it's rare to have a patient who wouldn't benefit from preoperative rehabilitation. I guess we use it probably the most in our adult reconstruction patients, total knee replacements, total shoulder patients, total hip replacements. They can be as extensive as 4 weeks of physical therapy, or it can be a one-time visit to get a home exercise program to get the patient going. It just kind of depends on the patient and what they need.
Okay. And I mean, you've done research on prehab? You're researching almost everything, Keith.
Not in the shoulders. I believe in prehab, definitely with ACL tears. When someone ruptures their ACL in their knee, that there's been studies that have shown that the outcomes are a lot better if you do prehab in the knee.
Right.
I haven't studied it in the shoulder. I think there's value there. The one thing that you have to be concerned about is if you're having surgery, some insurance companies limit the amount of therapy visits. And so I think it's more important to be able to do it afterwards, but I do think there's value if you can start it beforehand as well.
Well, I think the value of having strong muscles with which to sew into and to fix into, there it is. We have a bunch of questions. We appreciate your questions. Thank you. But let's do the telestrator first.
Okay.
We have a case.
Yeah, so this is a patient of mine, a 54-year-old gentleman from Brookings. This is actually the second shoulder surgery I did on him. We fixed his other shoulder a year ago, and then about 6 weeks ago, we went to the operating room to repair his rotator cuff, and we had the video crew there, and so we can kind of show a little bit about shoulder surgery. So this is arthroscopic shoulder surgery, kind of to get you oriented here. we're looking into the shoulder from back to front.
Okay.
And the patient is in a sitting position, so over here on the left side would be their chest. This is the front of the shoulder here. This is the outside of the shoulder. Down here is the humeral head, and this is a little bit of the torn rotator cuff up in this region here. This big dark space you see in here is the actual tear in his rotator cuff. And we're going to go through the surgery quickly. We're going to see a debridement, some removal of bone spurs and arthritis. Here I brought a shaver in. We're cleaning up torn and loose pieces of tendon and of labral cartilage to clean the shoulder as best we can. You see the shaving tool has suction applied to it, so it sucks these loose pieces of tissue in. It then trims them off and sucks them out of the joint. And I tell patients basically it's like Mary Maid showed up and cleaned up your room. Or like taking a handful of gravel out of your work boot. Once this is finished, you can see that the joint is clean of all this detritus. Now I brought the scope out and I'm putting it back in. In the previous space, the rotator cuff was the ceiling. Now the rotator cuff is the floor. And this shows the tear in the rotator cuff. So this is the hole in the rotator cuff you can see here. This is the rotator cuff tendon coming across, and then this is the bone of the proximal humerus or humeral head where the rotator cuff should attach. And before we repair our rotator cuff, we've got a little work to do up here. We've got to remove a bone spur and take some arthritis off the end of the collarbone. So in this picture, the bone spur is covered by this tissue above here, and you can see that this tissue is badly frayed. What's been going on is the rotator cuff down here has been coming up and it's been impacting this surface, what we call impingement, for years. The tissue on the spur has frayed as a result of that, but the bone is tougher than the tendon and it creates the hole in the rotator cuff. So we're going to get rid of that spur. We do that for a number of reasons, and Keith could probably tell you better than I exactly why this works, but I think of it as a couple of things. Number one is it makes the surgery a lot easier if I can get this thing out of my way and I've got a lot more space to work with. Secondly, I'm going to increase this distance between the rotator cuff and the bone above it, and that decompresses my repair so that the repair is able to heal without that bone impinging on it. And this is after I've finished that. Oh, here we go. We're just getting started. We're using this burr tool to remove the spur, and then this is after the spur has been removed. So the spur was here, and now the bone is up here, and so I've increased that distance, decompressing the rotator cuff.
Okay.
After that's done, we've got to remove the arthritis off the end of the collarbone. And in this picture, you can see the end of the collarbone. It's sitting right here. Remember when we were in the shoulder, the surfaces of the socket and the ball were covered with a beautiful smooth white cartilage. And this instead is a kind of ugly gray and thin. That's what arthritis, bone-on-bone arthritis looks like. And that's been found to be painful. So while we're in there, I'm going to use the burr tool to remove the arthritis from the end of the collarbone. And here you can watch that getting started. And then when we're finished, we've got this beautiful surface. We're down to the bone marrow, and in here are the stem cells, and they're going to come out and they're going to repopulate that surface with a smooth white cartilage.
Now that's the collarbone.
That's the collarbone. That's your clavicle, right? Exactly. And now we've got that done, we've got to repair our rotator cuff. So here you see me placing an anchor into the bone. And after I've screwed the anchor into the bone and extracted the insertion tool, you'll see the sutures coming out of the bone. People often ask me, how are you going to repair this thing through the scope? And the key is right there. Now I have sutures coming out of the bone. I can pass those sutures through the bone and repair that hole in the rotator cuff. So if you look at this, I've got 4 strands of suture, and I'm going to pass those 4 strands through the tendon like this, and then I'm going to tie my knots, and that's going to cinch the rotator cuff back down onto the bone from whence it tore. To pass those sutures, we have a number of different techniques. This is the suture passing device. It's kind of like a sewing machine. As the needle passes through the tendon, it picks up the suture and passes it through. And I'm going to do that 4 times with that particular device, and then we'll tie our knots. This is me tying the knots. So you can actually tie knots into tissue arthroscopically. You don't have to get your fingers in there to do this. You can see the suture pusher that or knot pusher that we're using to cinch that knot down onto the tendon, and that pulls our the tendon back down onto the bone here. Now you can see there's a little gap here, and to close that gap, I'm going to use what's called a suture bridge repair. I'm going to place 2 more anchors and take those 4 strands of suture and cross the repair with them, and that reapproximates that tendon down to the entire footprint of the rotator cuff, which is usually about 2/3 of an inch or so. You can see us tapping the suture down, or the suture anchor back into place. And after I've stuck both of those anchors down, we'll have a good solid repair. I've got to cut these sutures, and we have a remote scissors that we're able to accomplish that with, and that's what it looks like at the end. So this is the edge of the rotator cuff. This is our bone down here. The footprint of the supraspinatus or rotator cuff tendon on the bone's about that big, and we've reapproximated that tendon down onto that footprint, and we hope for good tendon to bone healing.
Wow.
Yeah, that's gorgeous. Great repair.
That was wonderful to see. I mean, you know,
You just did see it.
It was wonderful. It was wonderful. You know, actually, I've never seen that before. I mean, I don't think I've ever been involved with any orthopedic surgery in my training or anything. I've seen knees repaired by you on our camera, but this was good. We have a question from Facebook. 47-year-old man had a rotator cuff surgery on the left shoulder with not the best results. He had a fair range of motion, but pain and weakness. I've been told my right one is torn by physical therapists, and chiropractor believes I tore it a few years ago because of the trouble after the first surgery. Would it be worth it to have surgery after all this time? Keith.
You know, I think it should be investigated. You said this caller was in his 40s?
Yeah.
So the concern
47.
is if he's got a full thickness tear of his rotator cuff in a young person in the mid-40s, you're looking at many years to live, and their natural history of a rotator cuff tear, some people's tears get bigger over time. And if you decide to put it off now and not investigate the possibility of fixing it, and you come back in 5 or 10 years and want to try and have it fixed then, you might have missed your chance. It might not be fixable at that point. So I think it's a good idea to investigate that tear.
All right. A man from Sioux Falls has spinal stenosis of lower lumbar region and received a couple cortisone shots. Is putting a cage in a good option? Pete.
Well, neither Keith nor I are specialists in spine problems or surgery.
Yes.
Spinal stenosis is a serious condition, and it can be progressive and disabling. I definitely think it should be looked at. I'm obviously not in a position to say whether he needs a cage or not. But if he's concerned about the advice he's been given so far, I would seek out a second opinion from another spine specialist.
Yep. I encourage that. I think whether you're an internist and the patient is questioning and not quite happy, get another opinion. It doesn't mean that you can't come back. If a doctor is offended by you seeking another opinion, then you need another opinion.
Agreed.
A woman from Chester asks, what are some daily habits you suggest that can keep me from having to visit an orthopedic surgeon? Preventive medicine is the best medicine. Keith.
Yeah, being fit, as you brought up earlier, is probably one of the best things you can do. Avoiding tobacco use is an important thing. Trying to maintain as close to an ideal body weight is important. But it comes down to the things that we can prevent. Being fit's really important.
Right. And I would come back, I don't know that we have a good answer for people who don't have a ideal body weight. But people who are heavy, if they're in condition, they're better. It's no question about it, and I would say, you know, start with a slow walk and gradually increase it, and there's probably no better exercise than walking. You both agree?
I enjoy swimming.
But you're a shoulder guy. Why would you not say that? A 55-year-old man from Webster is a carpenter. His shoulders are fine while working. However, he wakes up with pain in the shoulder joint. What could be causing this? Ooh.
Yeah, so the two things that come to mind are rotator cuff tendonitis or subacromial bursitis, what we call impingement syndrome, often will cause pain at night. The other thing is early osteoarthritic change can wake you up at night. And it can be both in the acromioclavicular joint, the AC joint, the little joint on the top of the shoulder,
right.
Or it could be in the big ball and socket joint as well. I think it's worth a quick trip to the doctor, maybe an exam and an x-ray.
Right. Now, impingement, explain that. He brought it up. You explain impingement. That's
Sure.
a common problem, isn't it?
Yeah, I think Dr. Luby's pictures on his surgery showed it quite well. There's extrinsic impingement, which means that when you raise your arm up, the space between the rotator cuff and the bone, or that spur that Dr. Luby pointed out, becomes narrowed, and you actually get contact there, and you get attritional wear. There's also the concept of intrinsic and internal impingement, which is something that we see in baseball players and younger athletes, where when they cock their arm back in this position in the late cocking phase, that the back end of the rotator cuff hits the labrum and causes some friction through there. But you look at impingement, of all the reasons why people go to seek a doctor for musculoskeletal care, it's probably the third most common reason, aside from low back pain and cervical spine pain.
Well, and that's physical therapy can help, or?
Often it can.
Okay. Woman from Brandon asks, does Parkinson's disease cause shoulder problems? Would you know, Pete?
Parkinson's disease is a horrible disease and can cause problems in many different areas of the body. I'm not aware that Parkinson's in particular predisposes one to shoulder problems, but it's certainly not protective. And just like everybody else can get shoulder pain, Parkinson's patients can as well.
Well, and if you think about a Parkinson's person, they're at so high risk for falling. And you come down like this, if you don't break your wrist, you know, you destroy your shoulder. So I would say that. I mean, I would say falling is the biggest risk. I'm a 75-year-old and have rotator cuff surgery 6 years ago. It's currently hurting me. Is it worth getting repeat surgery? Keith?
Maybe. If you're hurting, it's worth investigating the cause. Potentially there are some non-operative ways to get this better. Physical therapy, as Chuck McCullough pointed out earlier.
Start with your physical therapist maybe and go from there.
It's with your physical therapist, your primary care physician, your orthopedic surgeon. Any of the three can kind of give you guidance there. There are times when people can have recurrent tears, and there are surgical interventions available to fix that, either repeat rotator cuff surgery. There's times that we do special shoulder replacements for this as well. So there are options, and if you're struggling, I think there's a good idea to get some advice from your doctor.
Okay, so now we have 8 questions, 5 minutes or less.
There you go. Speed round.
65-year-old man from Volga. I have a torn rotator cuff. Is a certain shoulder exercise you would advise in the weight room? Are there any that you would not suggest? Pete?
Okay, so the rotator cuff strengthening exercises that you showed us so beautifully earlier would be good. The things you want to be careful about are heavy lifting above shoulder height. So doing military presses, doing incline bench, those would probably just exacerbate the problem.
Okay, this thing.
External rotation, abduction or scaption, internal rotation,
Okay.
Those should be helpful.
This one, and this one.
There you go.
Had a knee replacement 5 years ago. It aches badly, especially at night. What could be causing this? I'm going to throw it at you, Pete.
Okay, so a lot of reasons for pain after total knee replacement. Number one, I would say it's an incredibly successful procedure. If you follow 100 patients for 5 years, literally 99 out of 100 would say they'd go through it again. So it's unusual at 5 years to still be having pain. Infection is a cause. Loosening is a cause. It can be bursitis or tendinitis. Very, very rarely an allergy to the metal components.
So go in and
Go to your
seen.
surgeon and talk it out.
A caller in her 60s is a runner and has decreased mobility in her great toe and at times pain. How can she continue running without pain in her toe?
Yeah, very common. Oftentimes you can get a spur or arthritis in that joint. One of the non-operative ways to consider is getting a stiffened sole or a steel shank put in the shoe. It takes a lot of stress off of that joint. Over-the-counter medications at times. There are surgical interventions that our foot and ankle specialist at Orthopedic Institute does at times if those don't work.
Okay.
So we can do some treatments there to try and help you return to running.
Right. So maybe my wife should have somebody check her big toe because that's who. I know that.
That's where that came from.
A 75-year-old man from Sioux Falls had knee surgery on the left knee, and the other knee is now bone on bone. What option is best, injection, exercise, or surgery? Pete?
I'd start with non-surgical management, physical therapy type exercises, topical analgesics, oral anti-inflammatories, maybe a corticosteroid injection or a visco supplementation injection. And if that fails you, total knee replacement is a great option.
Okay. Do you like rubbing topical, smelly, and non-steroidal creams on joints?
I'm all about what works.
I like that answer. A man from Wagner experienced tingling in his right hand ring finger most of the day, and surgery was done to remove the nerve at the elbow, but the surgery didn't help the tingling. What can be done to improve the problem? Keith?
Yeah, that's interesting. So it sounds like the surgery was something called an ulnar nerve transposition,
Right.
where ulnar nerve comes over the inside part of our elbow. And the physicians there move the nerve to the front of the elbow, so when you bend your elbow, it essentially takes a shortcut and there's less traction on that nerve. So I guess the question is that really the source of
And that distributes down the fingers.
Yes, typically the small finger and the ring finger.
That's the funny bone.
Funny bone nerve. So I guess the question is, was that really the spot where the entrapment was coming? So if you have a pinched nerve in the neck, it could potentially cause numbness in that finger. If you have a pinched nerve in the wrist as well, something called entrapment at the Guillen's canal, that can do that as well. So I think that deserves further investigation.
Okay, check it out. 4 questions, 2 minutes. Man from Wagner experiences tingling in his 40-year-old female was playing baseball, got a kink in her shoulder. At age 80, she still has that pain every now and then. How does she help this, Pete?
So throwing a ball at 40 years old, and she developed shoulder pain. It was probably rotator cuff tendonitis, possible torn labrum. 40 years later, still has some symptoms. If she came in to see me in the office, I'm likely to start non-surgical management by trying injection, physical therapy, anti-inflammatories, see where it goes.
Okay. 80-year-old woman from Wakanda has reverse shoulder surgery 10 years ago. Can't get that arm behind her back or up to her ear. I can cope with this, but why is my arm sore all the time between the elbow and the shoulder? It's been 10 years. Keith?
Yeah. So I think one of the mentions that she can't get her arm behind her back, and that's one of the limitations of the reverse total shoulder replacement. We do this to help people regain motion in the forward area up through here, or
So be
elevation
happy
of
with
scapula.
that. I mean,
correct.
okay, you
this
can't do that.
This is a limitation of the technology that we have with that. Now, I guess one of my questions here is, can you potentially have a pinched nerve at the neck that is causing pain in that area? We sometimes will get referred pain in that area. Theoretically, there could be loosening of the joint there. So if you're struggling, if you're not happy with your quality of life, I'd investigate that.
Come in. We've got 30 seconds. I'm over 60. I fell on my hip over a year ago. I've been doing PT recently. Would it be wise to have a shot? I do exercises each day. Would love to get back to walking, but it bothers me. Pete?
Yeah, so it's been long enough that it's unlikely this is a fracture after the fall. So it's probably what we call proximal IT band syndrome or greater trochanteric bursitis, and corticosteroid injections are usually very helpful for that problem.
Very good. And now for the winner of tonight's Prairie Doc quiz question. The shoulder is a complex joint of 3 bones. Can you name them? The answer is the humerus, the upper arm bone, and that's not a funny as a comment, the clavicle or the collarbone, and the scapula or the shoulder blade. They make up the shoulder and the bones of the shoulder, and it was Shirley Davis of Clear Lake who answered the question correctly. Thank you, Shirley, for participating, and a book will be in the mail to you soon. We'll be right back after this.
Because you don't want to miss out on the little things. Because you want to be there for life's important milestones. There are many reasons to get life-saving cancer screenings. More than 4,000 women die each year from cervical cancer, but regular screenings can prevent this cancer and catch it early. Do it for the people you love.
Promise?
Promise.
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 Make the promise to get screened. For more information about life-saving screenings or available financial assistance, visit getscreenedsd.org.
The shoulder is an elegant piece of machinery which can move and rotate in more directions than any other joint in the body. With such freedom of movement, however, comes less stability and more risk for injury. The upper arm bone, or humerus, and the shoulder blade, or scapula, make a ball and socket type joint. The ball is held into the socket by a complex of rotator cuff muscles, tendons, ligaments, and a rim of cartilage. This whole shoulder joint muscle system is held onto the chest and body by the collarbone, or the clavicle, and more muscles. Despite marvelous engineering and design, humans will overstretch and overuse their shoulders, and injuries will happen. Mr. A.B. had fallen off a tractor and dislocated his right shoulder when he was in his 30s. He's been active as a farmer for more than 50 years, but over the last 4 to 5 months, he's noticed a gradual worsening pain and difficulty shoveling grain. He told his wife he just can't take it any longer, and she made the appointment. The patient came to my office, like many farmers, a bit reluctant to explain his problem. A number of medical problems can masquerade as shoulder pain, and some of them are dangerous. A careful history taking and exam was needed. The pain was not related to exertion and relieved by rest, like that from heart trouble. It did not radiate below the elbow and didn't have associated neck pain, like that from neck pain nerve trouble. It was not made better by eating, like that from peptic ulcer problems. It was not made worse by a big and fatty meal, like that from gallbladder stones. Finally, it was not related to breathing, and there was no fever, like that from pneumonia. Mr. A.B.'s pain was clearly made worse with movement of the shoulder and nothing else. When his shirt was off, I noted both shoulders were symmetrical. With thumbs down and arms outstretched, it hurt as he raised his right arm. And when I bent that arm at the elbow and rotated it downward, he winced and protested. This was the picture of inflamed, swollen, and tender structures rubbing while trying to pass under a tight arch of bone and ligament. Mr. A.B. went to physical therapy, hired someone else to shovel, rested his shoulder, and over time, the injury healed and the pain went away. We take for granted the elegant engineering and design of the human shoulder. Well, a big thank you to our guests, Dr. Pete Looby and Dr. Keith Baumgartner of the Orthopedic Institute. We appreciate their volunteering to join us tonight. Thank you both very much.
Thank you, Rick.
Well, it's that time of year again. The flu season is coming. Now is the time to start getting flu shots. Remember, it takes 2 to 3 weeks for it to become fully effective. That does it for tonight. From all of us here at On Call with the Prairie Doc, until next time, stay healthy out there, people.
More than a cure for loneliness, having pets has an important and real effect on our lives. Pets make us healthy. Next time, On Call with the Prairie Doc.
Major funding for On Call with the Prairie Doc has been provided by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call Television as it continues to open doors for important medical information.
and by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota, and with the ongoing support of these individuals and institutions. Brookings Health System, Ophthalmology Limited, Avera Heart Hospital, Dakota Allergy and Asthma, Fishback Financial Corporation, Vance Thompson Vision, Aberdeen District Medical Society, Black Hills District Medical Society, Dakota Bank, Orthopedic Institute, Physicians Care Sanford Clinic Community Service Committee, and Swiftel Communication.